Hello, my name is Alma Hernandez, and my PDSA project is on fall risk assessment and prevention in the geriatric cardiac population. Issue identification. Falls are the leading cause of fatal and non-fatal injuries among adults aged 65 years. Between 700,000 and 1 million falls occurs in hospitals every year, and approximately 30 to 35% of these falls result in injury, and 11,000 falls results in death. Also, falls cost the U.S. healthcare system more than $19 billion, and it is proposed that this number will go up to $54.9 billion by 2020. Fear of falling is also defined as a geriatric syndrome that may contribute to further functional decline in an already frail patient. The hospital that I work at is called Anaheim Regional Medical Center. This is a community hospital that hosts 232 beds. I work on the telemetry oncology unit where we have 46 beds. This is an inpatient acute care unit. Mostly the patients are geriatric patients with multiple medical conditions. Common diagnoses is congestive heart failure, coronary artery disease, hypertension, MIs, COPD, sepsis, and end-stage renal failure. Also depression and dementia. On my unit, there has been 6 documented falls in the last 4 months. We use the Johns Hopkins Fall Risk Assessment and SAFE program, and this is what's used when the patient is admitted and for every shift. Some of the patients who fell in this 4-month period were documented as moderate to low risk. And some of the patients that were identified as high risk that fell did not have all the implemented SAFE program and fall risk interventions in place. For example, bed alarm, the yellow socks, and the yellow gown. Expected performance standards. According to the World Health Organization, recommends that fall prevention strategies should be comprehensive and multifaceted based on precise assessment and identification of fall risk patients. Also, the Joint Commission National Patient Safety Goal requires the implementation of a fall reduction program. This program should consider the medication regimen and also the ambulatory settings of the patient. The staff should also be aware of the medication effect related to these falls. Some high-risk medications, for example, are hypnotics, sedatives, psychotropics, antihypertensive, laxatives, and diuretics. And the Center for Medicare and Medicaid Services declares that falls related to trauma, such as fractures and dislocations, is a hospital-acquired condition, and it does not qualify for payment, so it would be considered non-payment. Root cause analysis, the case example. So in my unit, there was a 78-year-old male patient that had fallen twice during the same hospitalization. Both of these falls occurred during night shift when the patient had attempted to go to the bathroom by himself. He was admitted to the telemetry unit and diagnosed with CHF exacerbation and UTI. He had a history of CHF, hypertension, dementia, hyperlipidemia, kidney disease, and diabetes. The patient was identified using the Johns Hopkins Fall Risk Assessment as moderate fall risk. Some of the risk factors present at the time of the fall were the medications he was on, which were antihypertensive, antibiotics, and diuretics. Also, with his history of dementia, and he was on IV infusion of antibiotics at the time. The interventions that were in place were that he had a yellow armband fall risk and that he was using yellow socks that were non-slip. The interventions that were absent at the time was that he did not have access to a bedside commode or urinal, and the bed alarm was not activated. Also, the room was not very close to the nurse's station. Problem statement. So the main problem is that patients are not being accurately identified as having high risk for falls and are consequently not receiving enough of the fall prevention interventions to prevent a fall. Why did it happen? Current fall risk assessment tool may not be sensitive enough to capture the unique risk factors of the geriatric population, thus resulting in correct placement of high risk for fall patients at a lower risk category. When did it occur? So the fall risk assessment occurs upon admission and at every shift. And how best can it be avoided further? By properly identifying the correct fall risk category and implementing the correct fall risk precautions. Scope of the problem. So currently, nurses are caring for far more adults over the age of 65 than any other patient population. And falls cause not only physical injury, but they also cause fear and anxiety in the patient's families and healthcare workers. Also, falls have a significant financial burden due to treatment costs, increased length of stay, and complaints and litigations. Hey, listen. Stakeholders, patients and their families. There are increased safety and reduction in injury deaths due to falls. Nurses, implementation of quality improvement interventions, and unit hospital management and administration staff financial costs of falls. For example, the CMS does not reimburse for fall injuries. Solution, improvement goal, improve fall risk assessment to better identify patients at high risk for falls and accordingly provide more consistent and appropriate fall prevention interventions in order to prevent falls. Solution, in addition to the current fall risk assessment tool, adopt a customized fall risk assessment tool like the Henrik II fall risk model that is specific to the unique risk factors and characteristics of the geriatric cardiac patient population. This tool was developed by Anne Henrik in 2016 and is specifically for adult acute care population. This tool addresses common fall risk factors as well as those that are unique to the geriatric population like mental status, gait, diagnosis, medication, and muscle strength. The major strengths are its brevity, the inclusion of risky medication categories, and its focus on interventions for specific areas of risk, rather than on a single sum general risk score. So this is an example of the fall risk assessment tool we currently use, the Johns Hopkins, and the second photo is the Henrik II fall risk model, which is the one that should be used in accordance with or secondary to the fall risk assessment tool. They should both be used. So the solution implementation. So the Henrik II fall risk model should be used in addition to Johns Hopkins fall risk assessment at admission and every shift for the initial tests of the 5 patients. Apply unit fall prevention protocol according to fall risk identified in Henrik tool. Compare patients' risk category according to the Johns Hopkins versus the Henrik model. Involve and educate nursing staff and managers about Henrik fall risk model and its benefits and validity. Also measure and evaluate whether applying more intensive fall risk protocols initiated by the Henrik risk category resulted in successful fall prevention during patient stay on our unit. What this will have, the effect this will have on workflow and practice is that it will require extra time for nurses to assess patient fall risk. The Henrik tool is more detailed and comprehensive than the Johns Hopkins one. It also requires more time and effort to implement the more intense fall risk interventions that may be identified by the Henrik model. So the initial test of Henrik fall risk would be the 5 patients to assess them on admission and every shift during their stay on this unit. Also, to document if there are any falls during their hospitalization. Analysis. So data collection, to collect and record fall risk identified by the Henrik model and Johns Hopkins falls risk scales on each patient. Document fall risk intervention protocol category and interventions, and monitor and document any falls that occur in the group of patients. Analysis. Compare amount of patients identified as fall risk by Henrik model versus Johns Hopkins model. So did the Henrik fall model assessment better identify patients with high-risk fall? Is the Henrik model tool more sensitive to the risk factors than the Johns Hopkins scale? And were fall prevention interventions that were applied to the identified Henrik fall risk patients more effective in preventing falls during their stay on the unit? Preliminary results. Assessment with Henrik tool resulted in the identification of more patients at risk for falls as compared to the low-risk category of the Johns Hopkins scale. Henrik tool eliminated more risk factors for our patients that are missed by the Johns Hopkins scale. Fall prevention interventions per unit protocol for high risk were applied and resulted in no falls during the hospitalization. Next steps. Next steps would be to implement the Henrik tool fall risk model assessment tool on a larger scale to get more data to prove whether it really is effective. If the Henrik tool proves to be effective for our patient population, then we could begin by incorporating it into our admission and shift assessments, and also using it in a more standardized way, like computerized charting system. Also, educating nursing staff of the effectiveness of the tool and how to improve patient safety and quality of care is important. Effective fall prevention should focus on routine screening of modifiable risk factors and implementing interventions that specifically target these risk factors as opposed to over-reliance of fall risk score derived from a fall risk assessment tool. Thank you.